Hi, everyone. We're so excited because we have a very special guest tonight. Dr. Sharon Malone. Hopefully, we can get everybody here joined in just a moment. We have Stacy, we have Allison. Oh, I see Sharon's joined, so I don't see her yet, but hopefully she'll pop up here in a second. Do you see her?
No.
Well, let me see here. Let me try this again. Okay, let's see if that works. I wonder what's happening.
Have we ever done it with four?
Yes, we have. We weren't
Okay.
the one hosting it, but we have done this. It does
Okay,
work.
good.
Yes. She's unable to join. Okay.
I'll jump off.
Okay. Let's see if that works. All right, let's see if we can get her on now. But I know it works with four, so. Oh, there she is.
I'm
All
here.
right.
Oh,
Hi.
this fills me with such anxiety every time I'm like, oh, what happens? What happens?
Same, same. And
Hey.
I'm hoping we can get Allison back on here because it was saying that you were unable to join, and the tech of this every single time you're trying to talk and be relaxed while also trying to push buttons and invite people. So hopefully we can get Allison back here in a few minutes. Let me see. I'll
Okie
try
doke.
inviting her back. But in the meantime, welcome. We're so excited to have you. There we go. We have everybody now.
She's all here.
Gang is all
It's
here.
just like the worst thing ever. Anyway.
Well, Dr. Malone, we are incredibly honored to have you guest on our Instagram Live with Not Your Mother's Menopause. I'm going to introduce you with your bio, so if you don't mind, I'm going to just okay. This is short, but it's really
Okay.
good, and I think we need to do a little bragging because you are bragworthy. Um, Dr. Sharon Malone is a New York Times bestseller and author, women's health advocate, and chief medical advisor at Alloy Women's Health, a board certified OBGYN and certified menopause practitioner. She spent nearly 30 years in private practice before dedicating her career to expanding access to evidence based menopause care and closing the gender gap in midlife health. Her groundbreaking book, Grown Women Talk, and appearances on The Oprah Winfrey Show, the Michelle Obama podcast, CBS Sunday Morning, and Today's Show have made her one of the most visible voices advancing women's health today. In 2025, she served as a keynote speaker for the ACOG National Convention and was honored on the 2024 Forbes 50 over 50 list. A proud sister of Delta Sigma Theta Sorority Incorporated, she is a charter member of the Xi Tau chapter in Cambridge, Massachusetts, which recently celebrated its 45th anniversary. Not only that, but you were our keynote speaker at our inaugural event in January, and we're so excited to welcome you back to our next event in January on the 11th of 2026.
Well, thank you. Thank you. And thank you for having me back. I mean, that says a lot. Usually it's like, don't come back. No.
Oh my gosh,
No.
no way. You set the tone for our event, and you have been such a strong voice and steady advocate for all things menopause. And so tonight we're going to take some time to talk specifically about what perimenopause is, what menopause is, and particular interest and digging deeper into the disparity in care amongst Black women. So, why don't we start at the top and let's talk about what is perimenopause?
Perimenopause actually didn't get a lot of press. Everybody kind of knows what menopause is, but they don't understand perimenopause. it's the menopause transition. So it's that bridge between when you're in your peak reproductive years and menopause. And that bridge can be very long for some people. It can be as long as 10 years as you are making that transition. And a lot of women don't realize that it happens way earlier than they expect. I mean, if I say that the average age for menopause is 52, and you subtract 10 years from that to say, oh, well, then you could start at 42. But
Mm-hmm.
what if you're menopausal? What if you're going to be menopausal at 45? Then that means you may have started as early as 35. And so there is a broad range of when perimenopause actually starts. And because there's no distinct marker or there's no distinct blood test that signals it, just understand that perimenopause is a clinical diagnosis, which means you are in perimenopause if you are between the ages of 35 and 50 and still getting your periods regularly or not. You are officially in perimenopause because you have started to make that transition, whether you know it or not. And the reason why it's so confusing for women is because all of those symptoms that we talk about in menopause, hot flashes, night sweats, mood swings, vaginal dryness, irritability, that long list of symptoms can start in perimenopause. And you understand it's confusing because if you're getting your periods regularly or irregularly and having hot flashes, and you go to your doctor and say, what is this? And they'll go, oh, let's do some blood tests. They might be normal. Oh, when was your last period? 6 weeks ago. Well, then it's not menopause. And so that's why it's sort of flown under the radar
Mm-hmm.
for why women don't recognize what's happening. And unfortunately, a lot of doctors don't recognize what's happening either. But one of the little known I won't say symptoms, but just one of the little known signs of perimenopause. And the reason why it's important to know it is that the first signal that you get is really menstrual irregularities. And by
Mm-hmm.
irregularities, I mean sometimes the period, you'll be getting your period regularly, but it's coming sooner than it should. So if you've had a 28 to 30-day cycle, you may say, my cycles are now 25 days. That's a signal that you are starting to make that transition. And it's important that women not only know that this is happening, but I encourage every young woman to talk to your mother, your aunties, to your older sisters, if you have them, just to get a sense of, hey, mom, when did you go through menopause? Maybe she went through at 42. And that has implications because of fertility. And that's something we really don't talk about during perimenopause, is
Mm-hmm.
that your fertility is not gone, but it's not what it was also when you were in your 20s. And
Right.
so, because so many of us are starting our families later in life, you're entering perimenopause and you're wondering, why are you this otherwise very healthy woman with regular cycles is unable to get pregnant? And that is because you have started to enter that perimenopause. And we don't talk about the fertility issues as much because that's why I said I want you young women to know this. And not that there's necessarily anything you can do about it to change that, but you can make other decisions about childbearing. Okay, well, if
Mm-hmm.
you're 34 and your mother was menopausal at 40 and you want 3 children, well, then don't wait until you're 40.
Right.
Those are
Right.
just things that help you. They're just guideposts. And now that we have other technology, we have things like, cryopreservation of eggs or egg freezing. These are decisions that will help you before you get to the point where you're
Mm-hmm.
actually having a real problem.
All this resonates so much because I actually just did a post earlier this week on our channel specifically about me reflecting really recently about when my symptoms actually started, which was
Mhm.
37 after I
Mhm.
went off the pill. I
Mhm.
was very much single.
Mhm.
I had no reason to think otherwise. My periods were irregular. And then I started getting really hot at night. And then it was kind of like I would sweat and it was weird, but I was cold all the time. So it didn't really register to me. And I will say, amongst this group of the three of us, Stacy and I both had our children late. I mean, I was 40 when I had my daughter. It was
45. I was 45.
so we're like
You're in it.
in it at the same time. We're also having a baby, and yeah, it is a lot happening all at the same time, and really have it. It's a hard thing to pinpoint because you're hormonal from having had a baby and you are exhausted and you're having a lot of the same symptoms in postpartum that you're also having in
True.
perimenopause. So it's like everything is just mashing together.
That is exactly right. And even though I say to you that, oh, well, your fertility is diminished in perimenopause, and it is, but it's not gone.
No.
So, but
No.
obviously, I am that perimenopausal baby. My mother was almost 45 when I was born. And the next sibling to me was 7 years
Uh-huh.
older. So I'm sure my mother wasn't exactly expecting to have another baby, but hey, it happens. So that's the other part of perimenopause. Even when your cycles get irregular and maybe you're getting them every 2 or 3 months, don't assume that you don't need birth control until you have definitively crossed that line into menopause. And you are officially menopausal when you've gone up 12 months with no period. But again, everything is like, but except what if you have an IUD? What if you've had a hysterectomy?
Right.
Those are kinds of things you can't always use the period or lack thereof
Right.
as a marker, as to whether or not you are. And sometimes, that adds to the confusion. But I think that it's not, we're not trying to solve Rubrik's Cube here. It's not that difficult.
Right.
You at least have to have the thought in your mind. You have it in your mind, even if your clinician does not. So you bring it
Hmm.
up. Cerebral
Right.
glands.
And the other thing that's a great point. The other thing that I think is interesting is what if you don't have a parent or mom who went through menopause
Mhm.
naturally? Mine had a hysterectomy
Right,
after my sister was born, so we have no idea when it would have happened for
right.
her. So my sister is able to use me as a benchmark, but she's had her own issues, and we're experiencing it at the same time, yet we're almost 6 years apart.
Mhm.
So
Mhm.
that's also weird too. But um, it's a great suggestion to be able to talk to family members. But the one of the key reasons we named our group Not Your Mother's Menopause is because a lot of women do not want to talk about the change and what happens. And so it's really helping to encourage women our age and younger to have those discussions with our moms, and other relatives, aunts, whatnot,
Right.
earlier, or at all, really, because I know that there is a lot of stigma around that conversation.
What is encouraging to me is that the stigma is starting to be shed.
Yeah.
That we
Yes.
are having, I
Yes.
am having conversations with women out in the public sphere and they're like, yeah, hey, and they are talking about it in a way that never would have happened 30 years ago. So yay for that. This is
Yeah.
just raising awareness. And so thank you for what you do, because we're normalizing this experience because and many people have heard me say this before, but it is the one universal female experience if you live long enough. You
Yes.
may get pregnant, you may not. You may have a lot of things, but if you live long enough and you're a female and you're born with ovaries, you will be menopause. Or you will
Hmm.
be in
That's
menopause,
it.
one way or the other. There's no opting out of that
Right.
option.
I would like to opt out.
Me
I
too.
really would like to. I would like to opt into the no more periods, but opt out of everything else. How can we do
Yes,
that?
definitely.
Yeah.
So so on that note, what is menopause in relation to what you just described as perimenopause?
Okay. So menopause, I told you, is that point at which when you are using periods as your marker, is when you've gone 12 months, 12 consecutive months, I should say, with no
Hmm.
period. Okay. But what if you have an IUD? What if you've had a hysterectomy? How do you know? What if you've been on birth control pills? Because women can stay on birth
Yeah.
control pills right up to menopause.
Right.
That's not an unusual thing. Well,
Mm-hmm.
then sometimes this is one of the few times when you are unsure if you have an IUD. It's very helpful that in that instance to get blood tests just to say, am I fully menopausal, yes or no? And even though those numbers will fluctuate, you'll get a pretty decent sense of where you are by how high that number is. And if that number is normal, because it fluctuates from day to day, then it says, no, you're not fully done yet. But once
Mm-hmm.
you are menopausal, and the test that I'm talking about is called an FSH, follicle stimulating hormone. And that's a simple blood test. You get it done. And if it's 100, you're probably menopausal. If it's 30, maybe not, because the range is pretty wide, but it does give you a benchmark of where
Mm-hmm.
you probably are, at least in this process.
That's something that comes up a lot in these conversations about what the experience that women have when they go to their doctors and then they
Mhm.
want a blood test and their doctors will give them or
Right,
won't give them, and is the blood test accurate and stuff like that.
right.
So I think what you're saying is that is this what you're saying, that not until you're in menopause can that blood work be definitive?
Exactly.
Okay.
Exactly.
That's very
Because
helpful.
in perimenopause, it may be, let me just give you a framework of what's normal. Anywhere from FSH can be anywhere from like 2 or 3 to 20 in a normal menstrual cycle, depending upon, and it varies whether you're about to ovulate or you're about to get your
Right.
period. That's the range. When it starts to go above 30, then you're saying, you're probably in perimenopause, but it may be 20 if I check it 3 days from now. So,
Mm-hmm.
when you're in perimenopause, the hormones, and that's sort of how you define it, your hormones are fluctuating. Your estrogen levels are fluctuating. They may be high one day and low 3 days later. So that's why getting a particular number while you are still in perimenopause is not helpful. That's why we don't necessarily use that number to decide if and when to treat. We're going to treat your symptoms in perimenopause when you say you are bothered by the symptoms, not by
Mm-hmm.
what the lab sheet says. You can have a completely normal lab result on an FSH, but if you're having hot flashes and night sweats and changes in libido, and we have ruled out the other things that may be problematic because, and I don't want to get too wonky here, but if you're 30, then we should be looking at other reasons why you
Mm-hmm.
may be having these symptoms, not just blaming perimenopause for everything.
Right.
So
Right.
good rule of thumb is, but if you're between the ages of 40 and 50 and you're having these symptoms, chances are it's perimenopause as
Good.
a result.
Yeah.
And so I think that the real key to highlight here and what you just said is that it's when you start to become bothered by the symptoms. And that is where so many women run up against providers who do not believe them, are not educated, and they walk away not being treated, feeling like they're going crazy. And that is a huge reason why we, the three of us, and I know the work you're doing is to make sure that women understand what they need to ask for if the provider is not going to understand what they actually need.
Exactly. And that's real because there are many doctors out there who do not understand the difference between perimenopause and menopause and when to treat and when not to treat. That's the reality.
Yeah,
There are not enough menopause trained physicians out there, and there are not enough doctors that have had the adequate training even during their residencies that they
right.
know how to treat because we've got 23 years of doctors not being adequately trained. I'm old, but we were taught about menopause, and it really
Right.
stopped at about 2002 when the Women's Health Initiative came out.
And
Um,
please talk about that. That is one thing that I wanted to ask about specifically is in your care of your patients and how that treatment has changed. based on this, the Women's Health Initiative and that study, and like the before and after? Can you talk a little bit more about that specifically?
Yes, and I want for even though you may be hearing about it for the first time, and I'm saying you women who are listening, you may think, "Oh, wow, this menopause, this hormone thing, it's new." No, it's not new news. You know, hormone therapy for the treatment for the symptoms of menopause has been around since 1942. So,
Oh, wow.
and the
Okay.
same drug that we used in 1942 is still available now for treatment of menopause. It's Premarin.
Mhm.
So
Mm-hmm.
it's not like we didn't know what the signs and symptoms were. We used estrogen, which Premarin is a hormone that comes from a natural source. And that's why I say you have to be very careful when you say natural and synthetic. But the natural source is pregnant mare's urine. It comes from horse's urine. So you get some estradiol and you get a whole bunch of other estrogens that are specific to horses. So take that for what it's worth. But it works. Okay. It
You get it where
works.
you can,
It
Dr.
works.
Malone. You get it where you can.
They didn't know how to make it,
Right.
so
Yeah.
that was so they were looking for, they used to grind up pig and cow's ovaries and,
Oh
make
my
these
Oh my
little,
God.
gosh.
yeah. So it was actually, that was an improvement.
Yeah.
But I say that to say, so from 1942 until 2002,
It's a long time.
that's a long time. That's a long time to have had the experience with treating women in menopause. And there are some adjustments that we had to make along the way. We didn't know that that you needed to add progestin or progesterone to that regimen. We figured that out. But anyway, we're clicking along treating women all, for menopausal symptoms. We knew what that was. And then when the Women's Health Initiative came out, and I won't bore everybody with this but it was the study that changed everything, would put in women's minds that there was an association between estrogen use and breast cancer. And that was really what turned everybody, set them back on their heels, because they thought, oh my God, when you say the words breast cancer to women, it doesn't matter what you say afterwards about any medication. And so it really halted, women sort of threw away their hormones who had been on them and happy. And I happened to be practicing during that time, and I know
Mm-hmm.
exactly what happened. And women were like, "Oh my God, you're giving me this stuff, and it's going to give me breast cancer." The reality is that that was never the case. It
Right.
wasn't the case then. The study was misinterpreted, overly generalized, and that is sort of why we've had these 23 years of lack of education and lack of forward progress
Mm-hmm.
in estrogen. There's a lot more to be known about the real long-term implications of using estrogen. I mean, suppose, if when they started that study in the 90s, in the early 90s, suppose we had all of that data. The women
Right.
hadn't thrown their hormones out of the,
Right.
flushed
Yeah.
them down the
Right.
toilet. We would have some answers, definitive answers about
Yes.
Alzheimer's. We'd have definitive answers about cardiac disease and a lot of other long-term implications.
Mm-hmm.
But we know enough, we have enough observational data, because again, remember, we've got since 1942 to 2025. So that's over 80 years of clinical experience
Mm-hmm.
um, with using hormones. So I don't think anyone should be afraid of it or think that this is something new. No, it's been around.
It's very comforting to hear. Before we go on, because I do have some other questions and we're obviously wanting to talk through some other subjects, but
Mhm.
there is one person who commented that they're a breast cancer survivor, and I hope that they are doing well and thriving and healing. They said, "What symptoms can you request treatment for that won't cause cancer threats?" So I would assume it's the
If
symptom.
you're a breast cancer survivor, this is someone
Yeah,
who's already had breast cancer.
that's
Well,
what it seems like. Yes, in this.
okay, well, two things. One is that we've sort of revisited the whole breast cancer issue, because I think that the prevailing data now says that Estrogen does not cause breast cancer.
Right.
So let's be clear about that. It does not.
Right.
You know, and then we've looked at it again and said, oh, well, it's not the estrogen, maybe it's the progestin. And it's probably not the progestin either. This is something that's hard for people to sort of, we want to blame things, okay? And my risk for developing breast cancer is different than yours, and it's different from Allison's and different from everybody else's. And it's based on my family history, my exposures, you
Right.
know,
Mm-hmm.
and my, you know, and my specific genetics, and age, you know, and that's something that women don't realize is that your biggest risk factor for developing breast cancer in your lifetime is living long enough to get it. So this is a common scenario. Someone's been on estrogen. They've been on estrogen. They've taken their hormones for 25 years. Now you're 75, you get breast cancer, and they go, oh, I knew I shouldn't have taken that hormone.
Right.
You
Right.
know, that
Right.
that's what happens. Or you take hormones for 6 months, get breast cancer,
Right.
and you can't
Yeah.
blame, you know,
Yeah.
the life cycle of breast cancer cells is longer than that. So that's why I said estrogen gets blamed for a lot of things
Mm-hmm.
that really it should not be blamed for. But I'd say this about breast cancer. We are revisiting and looking at it differently because, again, this gets back to letting women decide, you know, with informed consent. We are there, and I would, for any of you who are listening out there, Dr. Corinne Menn, Menn,
Yeah.
is the best person to follow because she herself is a breast cancer survivor. And she is one of our prescribing doctors at Alloy. And she has done extensive research on this because it's important not just for her patients, but for her personally, because
Sure.
she had breast cancer at 28.
Oh my goodness.
And I will say too, one of the when I first started becoming interested in menopause, not only,
Mm-hmm,
you know, as a topic, and I read Estrogen Matters,
mm-hmm,
which
mm-hmm,
that book to me, I said,
mm-hmm.
you know, it just blows everything out of the water that we grew
Right,
up, especially in our generation. It's like, you
right,
know, we were at 2000 and 2000, you know, we were young and we didn't think
right,
about it. And all we heard was estrogen, breast cancer. And now
right,
I read that book and I just thought,
right,
oh, you know, this
right.
is, I mean, it was incredible to read all that, just to unpack everything that had
Well,
happened in the WHI.
and to give you, but to answer that specific question, for someone who is, you know, newly diagnosed, let's just say, and if the one thing to know is, was your breast cancer even an estrogen sensitive breast
Right.
cancer? Because they use
Yes.
markers. If
Right.
it is a triple negative breast cancer, then the thought is, well, if it's not sensitive to estrogen, then it doesn't
Mm-hmm.
matter what you take. You could take estrogen, but everyone, regardless of what type of breast cancer you have, every woman probably can and should use vaginal estrogen
Yes. Yes.
because
Yes.
So
it is
important.
it is not systemically absorbed,
Mm-hmm.
and 85% of women will at some point experience the what we call the genital urinary syndrome of menopause, which is vaginal dryness, painful sex, sometimes just painful itchy vulva, and you know, and urinary tract infections.
Yes.
So everyone can do that. Breast cancer, regardless of what kind of breast cancer you've had, yes, get vaginal estrogen. And for women who are newly diagnosed with breast cancer and it's an estrogen positive cancer, it's not a bad idea. We have now an alternative, which is Veoza, which is the
Mm-hmm.
medication that will treat hot flashes, but it only treats hot flashes.
Right.
So, you
Right.
know, you have any of those other 34 symptoms of menopause, it's not going to do anything about your bone density. It's not going to do anything about your, you know, your dry skin or hair falling out. It's specifically for hot flashes. So we have an alternative. It's not perfect, but for anyone who is concerned, I think that, you know, you have a few alternatives and not a lot of the other things. You know, we do have the antidepressants, you know, the
Mm-hmm.
SSRIs. They don't work that great. Let's be clear about that. You know, yeah, okay, we use them. There are a lot of other alternatives, the herbal things, whatever. I find that this is just my experience. So take it for what it is. And this is 30 years of experience because I've tried to give women alternatives to hormones for those who choose not to take hormone therapy.
Sure,
If
there
you
are
don't want
definitely
to take
those.
it, hey, no harm, no foul for me, but I want you to know what your options are so you can make a good choice. But someone who has had breast cancer 20 years ago as a young person, and now you're menopausal and you're having sleeplessness and painful sex and all of these other things that put you at risk, you're at risk for osteoporosis. Sometimes you may make the decision. It's like, I get it, but at 20 years, I'm probably cured of that breast cancer, early stage breast cancer, I'm probably good. Can I take hormone therapy when I finally get to menopause? And the answer to the question is, that's for you to decide. But someone should
Right,
never tell you, no, you can't.
Right.
With all things in medicine, we weigh risks and we weigh benefits.
yep.
And I cannot tell anybody whether you won't have breast cancer again 30 years out.
Hmm.
I don't know.
Yeah,
But as you said, what are the things that are most bothersome for you? I mean, there's quality of life, and quality
yeah,
of life matters. And I don't think anyone gets to make that determination for you other than you. And let me be clear, this is very different than someone who was diagnosed with breast cancer 2 months ago. You
Right.
know,
right, right.
we're not talking about that. We're talking about women who have gone through their treatment, they have not had a recurrence, and they are now, menopausal. But again, everybody can have vaginal estrogen, on a case by case basis as to whether or not, but that should be a conversation, not that should not be dictated to you
Yep,
about what you can and cannot have, because I'm old enough to know that 35 years ago, when I was in medical school, there was the thought that there are a lot of things that we used to do that we don't do anymore. For early breast cancer patients, they were told you can never get pregnant. Oh, because all that estrogen that gets flooded into your system in pregnancy, surely that's going to change your prognosis. And you will be, with all this estrogen, you'll end up with breast cancer. Guess what? No difference. So young women who are early survivors, and once they've completed their treatment, and I hate to even use the word they're allowed to get pregnant, but
right,
you
right.
used to be told you can't. And now it's a decision and it's not. And now that we have all these years of follow-up, no difference in prognosis, no difference in recurrence, whether you have a baby or you don't. So that's the most estrogen you're ever going to have in your system at any one time. And it
Yeah.
does not make any difference for outcome.
Yeah,
Interesting. You in this, I mean, the breast cancer topic is obviously something that we could talk about this
Yeah.
forever because then
Yes.
these are the questions, and
right.
these are the questions, these
Yes.
cancer related questions are the
Yeah.
questions that keep coming up. And I do wish that we could get to all these questions. But I do want to talk, you mentioned some of these real critical um, issues that can happen to women as they go through menopause. You mentioned cardiovascular disease, you mentioned Alzheimer's and things. I want to start to focus here a little bit, and I know that this is something that we all want to get to talk about. Speaking of these critical health issues, this is one of the things you talk about specifically in your book when you talk about your own personal family history, and you talk about your mother, and you talk about her experience, and you talk about the experience of the Black woman in the medical community, especially. I'm going to obviously, I can't say I have any experience. Obviously, I'm white, so
I have a little
I
bit.
don't
I have a
know,
little bit of experience with that.
Just a little bit, right?
so I mean, I did go to a doctor once. They were like, "Oh, this is just what happens," blah blah blah. But this systemic dismissal and and lack of thorough care is something that we want to talk about. That you talk about so much in your book. That for me, again, as a white woman, was just interesting, upsetting, all the emotions to read about that.
Yeah.
So I wondered if we could talk about that here, talking about the disparity of care.
When we talk about disparities, when it comes to Black women, there's probably no health outcome that's not worse for Black women. I mean, in the sense that, and breast cancer, whether you're talking about menopause, and there's something about the lived experience of being Black in America. It's not your genes. And let's be very clear about that, because there are a whole lot of ways to be Black in this country. I'm Black, somebody from Sudan is Black, somebody from Jamaica is Black, and as
Yeah.
well as American born Blacks. So
Mm-hmm.
what is it about this experience that makes outcomes worse? A lot of it is, lack of education and access to healthcare.
Yeah.
That's you cannot deny that that's a huge factor. But also a concept that Dr. Arlene Geronimus at the University of Michigan has coined called weathering, which is this concept of like it's all the things that are outside the individual. It is where you live, it is what you eat, it is what toxins you're exposed to, it is the um, micro and macro aggressions of living in a state of chronic stress. What does that do to your health? And that's why she uses this term weathering. It's just like it
Hmm.
wears you down. Your immune system is not what it is. So what we have found with looking at Black women in menopause specifically is that the experience of Black women, and for Black women in menopause, is that they tend to go through menopause earlier, about a year earlier. Their symptoms are more severe and they last longer. So that menopausal transition, which can last anywhere from 4 to 10 years, for Black women is closer to 10 or 11 years. Now, that's a long time to be miserable. That's a
Mm-hmm.
A long
long,
time to be
long
miserable.
time
Yes.
Yeah.
to not be sleeping, to have hot flashes. But the terrible thing about it is that to not know that there is something that you can use to alleviate those symptoms. We have this is something I think that women in general and Black women in particular, we have normalized suffering. We
Yeah.
just think from the time we get our periods that, you suffer with cramps, you suffer with PMS, you suffer with migraine, blah, blah. The list is long
Hmm.
of the things that women suffer from. And I think that as Black women, we almost expect to suffer.
Mm.
There is like this notion, if the model of suffering has been modeled for us. And like I said, and this is true for all women, and particularly for Black women, because for you to sort of exert your own agency, it means that you have to have someone who will respond to that. Okay. And the experience of most Black women, whether you have great health insurance or you have Medicaid or you have none, is that dismissiveness that happens with
Mm-hmm.
symptoms
Right.
is even greater. And that's why after a while, when you've complained or you've said something, you just stop complaining. You're just like, oh, well, I guess this is what it is. And you suffer in silence. And if there is one message that I give again and again and again, I'm like, why suffer? I'm not a fan of it. I didn't go
Yeah.
to med school to watch people suffer. Particularly if I know what the answer is. And the question is whether or not we are going to let fear, because
Mm-hmm.
that's another big factor, fear get in the way uh, of of choosing the thing that's going to alleviate suffering. And I say choose you. I mean, don't, so we know all these things
Absolutely.
about,
Yes.
yeah, about how the experience of menopause is different for Black women. And it's always going to be different for each individual person because, in that list of things that you can have, your 34 symptoms, you may have 30, somebody else may have two, but you'll have some and in no particular order. So that's why I said you draw the line in the sand about where it is that you feel that you are bothered, because every woman deserves to be her best
Heard.
self,
Hmm.
you
Totally.
know, to be productive, to feel well, to be well.
Yep.
Why wouldn't you choose that? Oh my God. Why
Yes.
wouldn't you?
Absolutely.
Yeah.
Absolutely.
Well, Dr. Malone, I have a couple of questions and a couple of comments. I don't know if you remember talking to me at our conference in January, and you
Mhm.
looked at me and you said, well, there is some silver lining coming,
Yeah.
maybe a little bit. And you gave me that little bit of hope. And here we are in 2025, right? And the FDA had their big meeting. Now, I'm a pelvic floor therapist, so I see women suffer all the time.
Mm-hmm.
I see women dismissed. Pain with intercourse and urogenital symptoms have been my 30 years of practice where I've had to beg physicians to give patients vaginal estrogen. So now to see this FDA meeting that happened in August, I'm not sure where it stands at this point in regards to vaginal estrogen and taking off the warning label off of that, which then sparked an enormous amount of conversation. I see a lot of comments here. Talk about testosterone, which was another thing that came up in that FDA meeting
Right.
of why we sell men's testosterone and not women's, and can, should women be taking testosterone, should they shouldn't, but what, here we are in 2025, where are we going? Like what is it that we're, how is the media and everything and all these conversations, I see all these comments coming through of
It's amazing.
on this live, it's like
Mhm.
amazing.
Mm-hmm.
Where are we going? Like,
I wear a couple of hats, and one of my hats is the advocacy hat, and
Mhm.
that is my book was about explaining to women how to advocate for yourself on an
Yeah.
individual basis. When you show
Right.
up in your doctor's office, these are the kinds of things you should know. This is how to show up. But then there's also what I call the big A advocacy, which is the collective advocacy that we as women, we are a mighty force.
oh yes, we
And let me say that unless and until we sort of make our voices heard and we start going to now, I grant it, the current situation is a little exceptional right now. And so we'll go with that. I think we all understand what's going on. But the reality is that we have got to start to demand that attention be paid to women's health issues,
are.
Yeah.
Mhm.
menopause being chief among them. I mean, we've got to start, we are so far behind the eight ball on that because of all those years that we lost. But it's not
Mhm.
just here in the United States, because when that definitive study came out, it's like the biggest is $1 billion study. It shut down research everywhere, not just in the United States, but everywhere. So all of these questions that we have still haven't been answered definitively. So we have got to start to demand more for women's health.
Mhm.
Women, they do research on men and then they extrapolate it to women. But now you've got to include women in clinical trials. Guess what? Clinical trials need to be more diverse, because now we know that the experiences of how um, different disease states affect different populations.
Yes.
Mhm.
Yes.
Absolutely.
So you gotta have that. And so that's the next big frontier for me, is making women aware of the disparities that exist in funding, in research. And to be quite honest with you, until I really started doing the research for my book, I honestly, I knew it was bad. I didn't know it was that bad.
Hmm.
I mean, it's way worse than I thought in terms of who's making these decisions. And
Mhm.
unfortunately, I don't say unfortunately, but the reality is that most of the research it's been the researcher pool has been overwhelmingly male.
Yeah.
And
Wasn't it 19, what was it, the
93
1990s? Right.
1990, right? Yeah.
1993.
When women started being
Right.
included. Crazy.
Exactly. Exactly. And that was all a result of that was the backlash and the overcorrecting for the thalidomide. You remember that
Yes.
we talked about
Yes. Yes. Yes.
Yes.
thalidomide?
Yes.
And they
Yes.
were so afraid, oh my God, we can't give this to reproductive age women. Okay, well, what about menopause women? I'm not going to have a baby. I think I'm good, you know. But a lot of that they didn't really want to do research on women, because we live in in a different hormonal state.
Yeah.
We're not steady state. We're not men. We don't make the same amount of testosterone, give or take a little bit every day. our hormones vary depending upon where we are in our menstrual cycle, and that affects study results. And researchers didn't like that. It's like, oh, I mean,
Such
how
a
Too
we gonna,
hard.
bother.
It's
Such
yeah,
a
too
bother.
complicated.
it's so complicated. What, how are we gonna, And it's like, well, that's the point. We
Right.
don't work the way
Exactly.
men do.
Right, right, right. Yeah,
So you got to include us so we know whether or not it works for us. So my big ask for everyone is to really take this issue to heart and understand that we, even though we may be having trouble now at the federal level,
yep,
states matter.
Yes.
yeah.
You go
Yes.
to your legislators, your governor, and you say these are the issues that are important to me for women's health. Make them respond. And you know what? And I think that for too long we didn't even know that the problem existed. So, now we know, and now we have a
Hmm.
charge. And please go to the Citizens Guide to Menopause
Yes.
Advocacy.
We have
Yep.
that linked on our website for all
Okay,
of you.
good.
That is
Yay.
linked on
Yes.
our website
Yes.
and
Unboxing menopause, right?
Yeah.
Yep.
Yeah.
Yay.
yeah,
Yeah.
that's
Because
yeah, the Citizens Guide.
if we all do our part, and then I think that we're collectively, there are too many of us to be ignored. It's easy to pick you off one at a time, but we're 51% of the population. So
We got to come
Yes.
together. We got to
yeah,
come
So,
together. Yeah,
absolutely.
yeah.
oh, well, we are so excited. I mean, every time I'm in your presence,
Same.
I feel hopeful.
Oh yeah.
But we're so excited to have you back to Maplewood, New Jersey. We are Not Your Mother's Menopause, NJ.com. For anyone interested near Maplewood, New Jersey, it will be January 11th,
Yes.
2026, a year later. And for those that don't have your book, Grown Women Talk, I know it's probably coming up
Oh,
opposite.
it's already in paperback
Oh,
now.
Oh,
look at
yes, that's
that!
right.
The
Yes,
book
Sorry,
is
I have
amazing.
the
congratulations.
signed version.
Yes, you got the original.
I will say that book, when you said earlier in the conversation, Dr. Malone, that you wrote your book as a guide to being a woman, how like, and I
Yeah.
read that book and I was like, this is amazing. This is like, okay, it is. It's a go to the doctor and say this.
Right.
It
Yes.
really is, a
Right.
fantastic resource to have. So people should
Right.
get that in paperback
Right.
or hardcover or
Yes. And
both.
all the music that you have attached
All
to
the
it. I'm
Oh
not
music.
yeah.
sure the
You got to
Easter
make it a
egg.
little fun. You
Yes,
got to
Of
make it fun.
course.
absolutely.
There's a playlist,
Definitely.
everybody.
I
Absolutely.
know.
Yes.
And I'm going to give you two shameless plugs. One of which for any of your listeners who are out there and look, I encourage you to go to your doctor. Go to your doctor. There's a lot of things. I was a practicing gynecologist for 35 years. Um, so there's some things that only your doctor can do. But if you go to your doctor and you are put off or dismissed, that's why I do what I do with Alloy
Yeah.
Health, because you
Yep.
shouldn't be limited by access because of where you live or the quality of the practitioners where you are. Every woman should be able to get this information and get access to hormone therapy should you choose it. And that is, so Alloy,
Yes.
is
Thank you for that work.
myalloy.com.
Yeah.
MyAlloy.com. Yeah.
Myalloy.com.
Myalloy.com. Mm-hmm.
And then I also want to let you know, I don't know whether or not you know this, but I have a podcast that's coming out.
We do know that. We
It's
should have
coming
said
out
that. When is that starting?
October 6th.
Oh my God, that's
Oh,
amazing.
menopause month.
Yeah,
Yay.
Yay!
of course, of course. And you know what? And here's the name of my show is The Second Opinion.
Oh,
And
love it.
and
Love
what
it.
I want to do, and it will be all things women's health. It's not just menopause. It's certainly targeting women, the over 40 crowd, and the things that we haven't discussed and should. But as I say, I don't know everything. I know a lot about what I know, but I don't know everything. And so we're going to talk about women's health issues and the things that I don't know. We're going to get a second opinion. So I will have subject matter experts in other things. So we'll talk about heart disease. Maybe we'll have a show about migraines. We'll have a show about cancer. So it's,
Pelvic pain,
yeah.
pelvic
Oh,
pain, and
oh,
pelvic PT.
if only I knew a pelvic floor therapist to get.
If only. If
If
only.
only. Yes, because these are things, incontinence. You know,
Yes.
do you know how
Yes.
many women walk around with incontinence and they're embarrassed to say
It's awful.
anything?
Yeah.
And the answer is not depends. No,
Correct.
that
Yes.
there's something we can do about that. So that's why I want women to know that and I also want to know when I do this show, I want to know what women want to know
Yeah.
because I want to be responsive. I'm doing this show. I'm not doing this show for me. I'm doing this show because I know that there is such a limited amount of time that FaceTime that women are going to get with their doctors,
Yeah.
even when you have one. It's just the whole nature of medicine has changed. So where else are you going to go to get an in-depth conversation about something? And you're not, and TikTok has been very useful. Let me just say this, but that's
Yes.
not the way that you're going to get a long form
No.
conversation about whether or not, what do I do to prevent uterine cancer, that kind of stuff. So I
Hmm.
want it all to be actionable and I hope that it's
Awesome.
helpful. I hope that it's helpful.
So we
Second
actually have
opinion.
some
We'll add that to that. We'll make sure we plug that on. We'll put that
Okay.
on because
yes.
this will live on our YouTube. This will live on our YouTube channel. We'll get that up there as soon as we can, and we'll make sure to include all those links that you mentioned on that.
And you
Good.
already have some requests for different things that they would love to hear about, like
Oh yeah.
migraines and prolapse uteruses.
Oh
So,
yeah. Yeah. We can talk about all of that.
and
Listen, if you and
testosterone came
strength
up as
training,
well. Oh, so much.
That's
Yes, so much. And if you ever need to talk to a marketing strategist
or a strength trainer.
for a reason, I don't know. I could give you a second opinion on a lot of things. It would be a difficult field.
That
Wow.
sounds
Dr.
good.
Malone, thank you so, so much. Really. It's
Yes,
always a
thank you.
pleasure. And as Stacy said, like there is something so calming about you and the hope that you
Sure.
give and really just you give us hope and really are such a mentor in this space. And we cannot thank you enough for all of the work you have done and continue to do.
Thank you.
Thank you for having me.
Thank you
Thank
so
you. We're
much.
We'll see
honored.
you in January.
Yes.
See you in
And
January.
we'll be listening on for your podcast before
Can't
Yeah.
then.
wait.
So
All right. I want feedback. So if it's not, you're like, too nerdy, not nerdy enough. Let me know.
Okay.
we love nerdy
Deal.
though.
Okay.
Deal.
All right.
Thank
Bye
you,
bye.
Dr. Malone. Bye bye.
Bye.